We're broadcasting from the Middle Tennessee Electric Studios.
Visit mte.com.
Middle Tennessee Electric, serving to make life better since 1936.
This is the WGNS Action Line. Talking with Rutherford County newsmakers
since 1947.
This is the WGNS Action Line. Now, your host, Scott Walker.
This morning we have guests from Ascension St. Thomas Rutherford, and today we're joined by Dr. Ernest Wright, and he's part of the Hal Allen Clinic and a neurosurgeon. Also, Daphne David, and she is the president of Ascension St. Thomas Rutherford. How are both of y'all doing this morning?
Doing great. Good morning. We're happy to be here today.
Glad to be here.
Starting off, tell us a little bit more about what you do day in and day out and what you see in neurology.
So I'm a practicing neurosurgeon with the Hal Allen Clinic. I think that's a name that's probably very familiar to many of your listeners since we've been in Middle Tennessee for just over 40 years now. My day-to-day life is taking care of patients with brain and spine problems. And as a neurosurgeon, what I do is I specifically do brain and spine surgery. We do surgeries that may be, from an incision perspective, pretty small. So like a surgery through a small, tiny tube, a tube the diameter of your index finger. So that's a real small, minimally invasive spine surgery. And it goes all the way up to doing things like fixing a curve in your back called scoliosis. And sometimes those surgeries, you can have an incision 3 feet long. And we also do, a fair amount of brain surgery. And those also range from small incisions to sometimes really large radical resections for patients who have things like brain cancer.
I guess one of the things that I hear more about than other things related to the spine would be like spinal fusions and things like that. What could they have, I guess, that leads to that?
Well, there's all kinds of reasons why you'd have a spinal fusion. I'll explain a quick thing, which I think patients hear about fusion often. What fusion means is instead of having a segment of your spine that moves, a surgeon puts in some hardware, oftentimes screws and rods, and it converts it from a segment that moves to a segment that doesn't move. And you might do that for something like a trauma, like you experienced, like you were saying, an auto accident. Sometimes it breaks the spine and you need to stabilize it. And so you fuse it by putting in screws and rods to restabilize things. But sometimes you do fusions for also just age-related conditions. So it doesn't always have to be an accident.
What are the most common things you see here in Middle Tennessee?
Well, I'll tell you, the most common thing is probably the most common thing that happens to all of us, which is aging. And I often will tell my patients, it's not, aging is not for the faint of heart. Many of our patients work hard. Everybody here works hard, and many of our patients work very physical jobs. And there's just a lot of wear and tear that comes with that, whether that means, working out in the sun or working in a factory. We just see a lot of patients who've had a lot of hard work in their life, and as they age are starting to reach a point where the pain prevents them from even doing basic things, and that's the point at which we try and step in and help. And oftentimes, I will say, it's not surgery. From a philosophical perspective, all of us at Hal Allen really want to make surgery the last option. And there's lots of things that we try and do before surgery to try and get patients better.
Now, Daphne, you were saying before we went on the air, some of the numbers of surgeries and stuff that are performed through Ascension St. Thomas, the numbers are large.
They are. Over the last 3 years, we've performed about 2,300 neurosurgery procedures. That includes both spine and head procedures as well.
That's a lot. That kind of surprises. Is that in Rutherford County alone, or is that all of Middle Tennessee?
So that's specific to Rutherford, and those patients can come from inside Rutherford County or the surrounding communities to receive the care that Hal Allen provides. And they do such a great job, and they're great partners as well. So that makes the opportunity to care for the community so much better.
That's wild. Over 2,000 surgeries for spine-related issues, and I guess I'm surprised by that.
We see nearly 100,000 patients in our emergency departments annually, and that's between the main hospital as well as our West Lawn campus. And so it is one of the top 5 busiest ERs in the state. So when we're talking about the surgeries, a lot of that comes from the ER, but then there's also the aging population and others that have challenges that come outside of the ER. And so with that amount of volume coming into one spot, that certainly makes sense to have that many procedures. And as well as I do, the growing community, it's significant. We're close to 400,000 in Rutherford County. and continuing to grow. And so we're going to see that number grow even larger.
Definitely so. And by the way, for those listening, if you have any questions, feel free to text those in. Our phone number is 615-893-1450. Dr. Wright, going back to you, I know we all have back problems, it seems like. And as we age, like you said, we're going to have more. Things like spinal stenosis and just arthritis in general in the back, is that pretty common once you hit, 40, or when do you start feeling the effects of age?
Well, I think the answer is yes. And I'll tell you a funny story. Anybody who gets an MRI will often get an MRI report. And oftentimes patients will show up in clinic with an MRI report that's 3 pages long, and they'll be panicked because they'll say, this MRI report makes it look like I'm dying. And I look through it, and the fact is most of that report is just talking about exactly what you said. It's arthritis, it's age-related changes, degenerating discs, spinal stenosis, and virtually every single person has some element of that as you age. It's just inevitable. I tell patients who bring in these long reports, this is kind of just saying that it's kind of like wrinkles on your skin. It just means that you've been alive for a while.
Yeah.
And it shows that you've lived an active life. So it's just par for the course, and that's normal. I think the question is, what do you do with that information? And again, oftentimes it's really just about making some small tweaks or giving them a little bit of non-surgical help to help them get back to doing the things they love.
One of the questions we were texted, it's asking what are some of the early warning signs of any neurological disorders that people often ignore?
The most common one is a loss of balance. And that's something that's particularly relevant to the spine, because if you get stenosis that's so bad that you start to pinch your spinal cord, oftentimes that's the first sign. It may not even be pain. And loss of balance is such a common thing that I think it's fair that many people would just say, well, I'm sure I'm just aging. But if you start to really rapidly lose your sense of balance, that's something that I wouldn't ignore, something that, you should have looked at, whether it's your primary care doctor or coming to see us. One way or another, we like to make sure that doesn't mean that there's something more serious going on.
When you say loss of balance, some people out there are probably panicking. They're telling themselves, I'm 50 and I can't do such and such anymore like I used to. How much of a loss of balance are we talking, to where you're walking a straight line and you just fall over, or is it more subtle than that?
Yeah, it can be more subtle. I'll give you a couple examples that to me are abnormal. So, 2 things that I hear very commonly from patients with respect to balance that indicate that there might be something going on. Number 1, if you close your eyes in the shower and you're going to shampoo your hair and you feel like you can't stand up, like you have to put your hand on the wall when you close your eyes, that's a little odd. And I think that's something I would get checked out. The other thing is, if you get up in the middle of the night, you're going to the restroom, and for most of us, you've walked to your bathroom 10,000 times. If you find yourself bumping into walls or falling over on that path that's pretty well worn, that again would be an indication that maybe something else is going on. I wouldn't panic, but I definitely think that it's the sort of thing where you'd like to mention it to your primary care doctor. Just make sure that we get it checked out. And if there's something going on, it's always better to catch it early. So
both situations, you're in the dark. Your eyes are closed on one, and the other one, you're in a dark bedroom. So does that have something to do with it?
Well, that's a great pickup on your part. And exactly. So whether you realize it or not, if you start to lose your balance in your sense of where your body is in space from your spine, your eyes will make up for it. And that will, in a sense, kind of cover up the problem. There is a sense, it's called proprioception, is the medical term, and it is basically the sense that allows you to close your eyes and know where your limbs are in space. If your spinal cord starts to get pinched, that's the first thing to go oftentimes, is that sense of proprioception. So what it means is that your brain doesn't necessarily know where your body is in space. If your eyes are open, your brain can usually use your eyes and the information from around the room to correct that sense of balance. But when you take that vision away and you have to just rely on that proprioception, it starts to become obvious that something's not right.
Another question, my doctor recommends I get a spinal cord stimulator, and I've got one friend whose husband has one and can't stand it. And then I have another friend who says it changed their life, and I don't know really where I am in deciding. Is that common as well, putting spinal cord stimulator in your back?
Yeah, so I'll tell you, it's pretty uncommon. And the way that works...
That's good to hear.
Yeah. The way that works for your listeners is a spinal cord stimulator. It's a little paddle. It's an electrical device that gets placed on top of your spinal cord. It's implanted surgically. And what it does is it emits little electrical signals. You can think of it kind of like a TENS unit that sometimes you put on the skin. And it emits electrical signals that interfere with pain messages going from your spinal cord to your brain. So when you're in a situation where you have a problem that can't really be fixed and you're having pain, this is kind of like the option that is offered, because it's an acknowledgement to say, well, we can't fix the problem, but if we put this in, it might decrease your pain by interrupting pain signals going from your spine to your brain. And the question that your listener posed is exactly the one that I get all the time, which is, I have family members, I have friends, or I've done research on the internet, and what I've heard is very polarizing. It's love-hate. And so what do I do now? And what I tell patients is, whether you've been told or not, there is a trial procedure as part of this. So the initial step in getting a spinal cord stimulator is they put a temporary one in that's put in through the skin in the office, and you can essentially walk around and you can try before you buy. You get to see the effect. So I don't think this listener has much to lose by undergoing the trial. My understanding is it's a pretty low risk procedure to have the trial done. And I think if you get the trial place and you're feeling relief, that's probably a good indication that this might help. And on the other hand, if it doesn't help a lot, it's probably not worth going through with having the surgery to get the permanent one placed.
Do you recommend people turn to Google before they get a procedure done? Because I don't think I would.
That's a great question. And, it happens very often nowadays, as you would suspect. And what's funny is patients will often apologize before they ask a question that they got from Google. They say, well, I've been Googling. I'm sorry. I know I shouldn't. My take on that is you absolutely should. I think it's great for patients to do a little bit of research, think of some questions, think of questions that maybe other people have asked on the internet that they wouldn't have thought of themselves, and bring those questions in so we can have a conversation. So I think internet research is a great conversation starter. I think most people understand that anybody can write anything on the internet, so it doesn't mean you're getting an expert opinion, but if it helps you think of questions, I think it's such a great tool to have.
With a spinal cord stimulator, how long does it stay in? Because you got to, I'm assuming, recharge the thing every once in a while, but how do you do that?
Yeah, great question. So a spinal cord stimulator is essentially that little paddle that I was talking about, and it's got wires, and the wires are connected to a battery pack that's all underneath your skin. As a resident, a long time ago when I was training, we used to change out these batteries. So your battery would expire, and we'd do a really quick small surgery, open you up under anesthesia, swap out a new battery, and then these patients would go on with their lives. And my understanding at the time was batteries lasted years. I don't know if the technology is here yet, but just like you can wirelessly charge your phone, I'm pretty sure you can wirelessly charge some of these stimulator batteries nowadays.
And I guess depending on how high you have it turned up each day and how long, I mean, it all goes into the lasting life of the battery.
Yeah, I think that's right. But my impression was that these things typically last years in terms of a battery. So I don't think it's very often that you're getting batteries changed.
I'm envisioning someone laying down on a battery charger, which is likely not the case, but that's where my head went with that.
I
Plugged
think
into a wall.
Yeah, right. No, I actually don't think you're too far off. I think they put a little pad on top of the thing on the skin, and it charges just kind of like your phone. So I know that's out there. Yes.
Plug in next to your phone each night.
Right, exactly.
Another question somebody just asked, stress is something I guess we all experience, and can stress actually change the structure or the function of the brain itself? Stress is something I guess we all experience, and a lot of folks have it.
Yeah. So I'll say, I remember, and this harkens back to a long time ago. I think this was my college neuroscience course. Lots of studies show how stress can really impact your brain, and the most critical part for everybody out there who is a parent or interacts with children is stress can really impact the development of children's brains negatively. There have been studies that have shown that kids who are in high stress environments have much less stress tolerance when they grow up, and also have less of an ability to regulate their emotions. So I think it affects all of us. There's no question. It certainly affects kids. And stress at a certain level is certainly not a good thing. And I think we all try and cope with that.
It seems like stress and sleep are the two big ones that you always hear doctors say, minimize your stress and increase your sleeping habits.
No question. And I tell patients often, because that post-op, post-surgical period is such a big part of my life and my patients' lives. I tell them, getting good sleep is critical for your recovery. And the opposite, I can say I'm probably also a sleep deprivation expert from all those years of residency training. You just don't feel good when you don't sleep well.
Can sometimes just simply changing your lifestyle, getting better sleep, things like that, and reducing stress, can that help out problems with your back or ongoing migraines, let's say?
I think it's definitely, no question. And I will say that even more broadly, you could ask me just about any health condition, and I probably would have said yes.
Yeah.
And I'm not an expert in all things by any means, but I will just say that, there is this tight link between your mind and your body. And mental wellness is really fundamental to physical wellness.
Another question, how serious, and this goes back to, I guess, balance and everything, but it says, how serious should someone take dizziness or balance problems? And I know you did touch base on that, but I guess dizziness, it seems like that's tied to balance as well.
To a degree, and I would say, it is more often than not nothing. Most patients will have dizziness or vertigo or imbalance, and 99% of the time, it's really just a self-limited condition that doesn't mean that there's anything bad going on. But if it's persistent, it's getting worse, I think it's the sort of thing where I wouldn't say it's serious. I just wouldn't ignore it. I'm a big fan of listening to what your body is telling you and believing the things your body is telling you. And so if your body's telling you, hey, I'm dizzy, I can't do balance, and it's getting worse, I just wouldn't ignore it.
Yeah. Again, with us this morning, Dr. Ernest Wright, and part of the Howell Allen Clinic, and you practice here in Murfreesboro. Now, do you also go to other hospitals?
I do. As part of our practice in Howell Allen, we all serve outlying communities. I'm really proud, very honored to serve this community among others. I also go to clinic in Manchester. And so I think we've all of us, we have 15 surgeons right now. All of us have at least one or multiple satellite clinics because we realize that the need in Middle Tennessee is not concentrated in big cities. Yeah. It's all over. And instead of making, 30 or 40 patients drive to see me in clinic every day, it's actually a lot easier for our surgeons to drive out to meet the patients where they live.
Yeah, I can see that.
Yeah.
Another question we had here, it says, I suffer from CN3 palsy from a skull fracture years ago, and I am now having a lot of neurological issues. Do you have any ideas on how to improve this? First of all, what is CN3 palsy?
So I think that caller or person who texted you is referring to the third cranial nerve. That's one of the nerves that comes out of your brain and controls your vision. Vision is probably your most sensitive of all your senses. It is super finely tuned. And whereas with hearing, you can sometimes lose some hearing or lose some function of the nerves that do that. And in many ways, you might not really notice it a whole lot. In fact, sometimes I'm surprised by how much sense people lose in terms of hearing before realizing something is going on. Vision is totally different. If the nerves controlling your vision are even just a little bit off from, say, an injury or an infection or tumor, it's very profound. Patients really notice it. It's very debilitating because we count on our vision so much. And when things don't look right, meaning you're seeing double, or things are hazy, or sometimes you miss a part of your visual field, like there's just a hole where you can't see anything in a part of space, patients really suffer from that. It's hard to answer that patient's question without knowing exactly what their issues are, because the injury has been so long-standing. Typically, there is a window within which you can heal from some sort of brain or cranial nerve injury. If it's been many, many years, I would say most likely that injury is probably permanent. And in terms of making accommodations, it's going to be more questions for therapists, occupational therapists, physical therapists, to acknowledge that, hey, this injury has happened. You're probably not going to be able to heal, but what could we do in terms of accommodations to help you live your life better?
So how big of a role does physical therapy play in that patient's life before you go to the idea of surgery?
It's huge. So, and both before surgery and if a patient does have surgery, after surgery. So I would answer your question by pointing out that surgery is never in and of itself a cure. I tell patients this all the time. I can never make you better than God made you. What I can do is try and help with the problem, but there's a part in which the physician can help, and then there's a part in which the patient's input along with a therapist is critical. And it's critical for either avoiding surgery in that preoperative period, or it's also critical for a patient to have a good outcome. So I would just say physical therapy, absolutely fundamental, and we try and use it as much as we can, whether it's before surgery, after surgery.
Here's not really a question, more of a positive statement. It says, good morning, Dr. LeBeau saved my life years ago, and I just wanted to say thank you to the Hal Allen Clinic. Dr. LeBeau is obviously part of the Hal Allen Clinic.
Yes, totally. I would say I so appreciate that, and I tell our patients all the time, I mean, you are the reason that we exist. You're the reason we go to work in the morning, and to hear that sentiment, it just makes everything we do feel so meaningful and worthwhile.
How often do you have patients come back to you, years later and say, you may not remember me, I was in an auto accident and, such and such happened, you did the surgery, but how often do they come back to you and just say thanks?
In the clinic, not that often. And I'll say it's probably a product of the fact that they're busy and we're busy. We have a lot of patients trying to get in, and we're always trying to get more availability for our patients who have issues. Yeah. So it's probably not that easy for them to just drop by and say hello. But in public, I'd say running into patients is always really a wonderful experience. I can't describe how amazing it is to see somebody that you've seen in a hospital bed in the worst times of their life out in public enjoying a meal with their family. It's incredibly gratifying, a really moving experience. And also oftentimes get a lot of letters and cards, just kind of writing about the experience of illness and their journey through illness. And it's incredibly meaningful for us.
I'm just thinking, if I had an auto accident, had life-changing, I don't think I would want to go back to the hospital, but I didn't have to.
Right.
So
right. There's probably a little PTSD there, understandably.
Yeah. Here's another one. It says, name's Angela. I've had 5 back surgeries. Wow. And now suffer from muscle weakness. Physical therapy seems to only aggravate the problem. Is this common after back surgeries? And I guess first, why would somebody have to have 5 back surgeries?
Yeah, it's a great question. And this is one of the greatest fears and concerns of patients. And they'll often say, much like this person who texted in and said, well, I'm okay with having a surgery if I need it, but I don't want to have another one, and I don't want to turn into somebody who's having to have multiple surgeries. And the reason for that most commonly is that if you come in today and you've got a problem and it's at one disc, we can certainly do our best to fix that. But if you've got a problem, if you've got arthritis and degeneration at one place in your back, you usually have it everywhere. And as time goes on, oftentimes other parts of your back will wear out. And fortunately, people live a really long time today. So for a 50-year-old patient who comes in and says, Doc, I know I've got this problem. I'm suffering. I'd like you to fix this, but I want you to tell me this is the only surgery I'll have. I'll tell them, I hope you live to 100. It means you might live another 50 years. You're only halfway through your life. You've already worn out this one disc. I can see a couple other here on your MRI that are having some wear and tear. They don't need surgery, but there's wear and tear there. You may end up wearing out those other parts of your back, and you might need another surgery. 5 surgeries is a lot, and I think that the issue, as I explain to my patients, is every time you do surgery, there's scar tissue that forms, and that scar tissue makes further surgeries more painful. It makes them riskier, and it makes them harder to recover from. So for this person who's texted in, and I truly have empathy for 5 surgeries, I think this person is probably suffering from a lot of scar tissue, muscle weakness from having that muscle having to be cut and opened again and again. And I think therapy is, I know that they've not had great success, but therapy directed at core strengthening is probably the best shot of rebuilding that muscle, as hard as it may be. Yeah. And oftentimes therapy may make you feel a little bit worse before it makes you feel better.
I know you mentioned some patients come in with the results of their MRI with all these incidental findings and everything. So I'm curious if this one is going to be one that people come in with. But the person asks, it says, do you treat spine hemangiomas? It says, mine are painful, but it seems like a condition that is continuing throughout my life. And it's always found on the scans that the doctor does. What exactly are those on the back?
It's essentially a ball of blood vessels that forms inside the bone. It's something that you can be born with, but it can also get worse or grow with time. In the olden days, they used to get treated. They used to get, a lot of times, they get procedures and surgeries and that sort of thing. The results were not great for pain. So hemangiomas, I would say we don't have a great treatment for pain associated with hemangiomas, but there is a certain situation in which you need to pay attention to that hemangioma, and it's if it gets so big it starts to press in the spinal cord, and that might cause some of the symptoms we've already talked about, like difficulty with balance. And if that's the case, it's not about treating pain, it's about preventing a patient from losing function. And so that's really the case in which, as a surgeon, I get worried about a hemangioma. But from a pain perspective, there's not a great treatment that is highly effective for pain associated with that.
Hemangiomas may not necessarily be a danger to the patient, just uncomfortable to the patient, ongoing, I guess.
That's right. And they're rarely become something dangerous. And I would point out to this person who is writing in that I see hemangiomas very, very commonly. It's very common.
Is that one of those incidental findings that people notice, I guess?
Yes, very much so. And also, oftentimes, sometimes even their primary care doctors get worried.
Yeah.
And we'll send them in because they want them to have a discussion about these hemangiomas. So understandable to be concerned, but I'd say in most cases, it typically is something that we don't really treat, just watch.
Scar tissue, arthritis, those are, I guess, normal things to see.
Very normal, very, very normal. Scar tissue after surgery is a guarantee.
We have a knee question, and we'll get to that in a second. I don't know how much the knees have to do with the back, but
I may know
we'll
just about as
out.
much as the patient about knees this far out from medical school.
This next one says, my wife has CRPS and asking, do you treat CRPS and how often do you see it go into remission?
So I think what they mean by CRPS is complex regional pain syndrome, and that has effectively evolved into a catch-all term for when a patient has a lot of pain in a lot of different parts of the body, and from a medical science perspective, we don't understand why this patient's having pain. And that happens often. Medical knowledge is not perfect. We do what we can with what we know. And this is one of those conditions where I'm not an expert in it, but my understanding is there's not a really clear understanding of why these patients are having pain, and that makes finding relief harder. Because many ways, you're not really treating the problem when we don't know what the problem is. We end up treating the symptoms. And as a surgeon, I don't have a good treatment for CRPS. I believe that's typically treated by our pain management colleagues.
Are you sometimes, when a patient comes in, when you see problems like that, complex regional pain syndrome, do you have to refer them elsewhere? I mean, are there specialists out there who focus on things like CRPS, but are there in Tennessee?
Yes. And that's a very common, if somebody is diagnosed with CRPS, I'd say it's very common to refer them to pain management. And as a broader theme, what I would say is it's very common that patients will come in and they may have vague symptoms, and I might be able to explain some of it, but I can't explain all of it. And it's important, I think, as a physician to say, hey, look, there's things that we don't understand and don't have answers to yet. And back pain, as common as it may be, is sometimes one of those things where you look at somebody who's got an MRI that looks good. I can't really see a clear reason for back pain. That's one of those instances where I explain to patients, hey, you know what? With the knowledge that we have right now as a society, I don't have a great explanation. Doesn't mean your pain isn't real. It just means that we don't understand it. And in those instances, certainly surgery is not the answer. The answer is going to be trying to figure out a referral pathway, whether that's therapy, whether that's a pain management physician, to try and give you relief, even though we can't describe exactly where the problem is coming from.
With problems like that you see in your office, is it a lack of just not enough cases of it to where people are focusing studies on whatever that issue, like CRPS, may be?
Mm-hmm. I think it's a lack of scientific understanding. Like, genuinely, all the time, scientists are researching an understanding of pain, trying to understand where pain comes from. And despite it being 2026 and, we're talking about sending people to Mars and all this stuff, there is a lot about the human body that we don't know.
Yeah.
And it just reflects limitations of knowledge. And that's why I think it's important that as a field that we continue to study these things, try our best to understand things better for the sake of our patients.
Pain to the brain. I mean, you're talking about everything from interrupting pain signals that go to the brain, but how closely are all these things tied together?
Pain is one of the great mysteries of life, because you can't really see it and you can't necessarily take a picture of it. and that it goes back to my statement about the MRIs. I've seen patients with a terrible MRI. I mean, I just really bad stenosis, and I'll walk in and they have relatively little pain, which is kind of a surprise. On the opposite end, I've seen patients who are in terrible pain, and I believe them. MRI actually looks pretty good. So pain is not well understood. It's really an interesting phenomenon, and I think there continue to be studies of it. And there's ways you can try and document it, like oftentimes patients in pain will have high blood pressure or a fast heart rate because they're hurting. But ultimately, it's very hard to objectively see pain as from a medical perspective, and I think it's something that needs to be continued to be studied.
We'll try the knee question now.
Okay.
It says, I had knee replacement 5 years ago and told the doctor it didn't feel right from the first day. And after my 1-year checkup, the doctor told me the knee was unstable and needed to be fixed. And now 5 years later, I'm thinking of having it fixed, I guess surgically fixed. Would you recommend a different doctor, or should I see one who didn't actually, I guess, do the surgery the first time? I have to kind of read in between the lines on some of these questions, but I guess they're asking, should they get a second opinion, and should they try a different doctor altogether?
I think I read that question as really one about second opinion when you've had an outcome that you're disappointed by. I always tell every patient, anytime they bring it up, well, should I get another opinion? Absolutely yes. Because what I'm really hearing when someone asks about a second opinion is I'm hearing a patient who says, I'm just not quite sure, or I don't feel totally confident. And I think that you really need to, when you're talking about surgery, when you're talking about procedures with risk, I want patients to feel confident, certainly for my patients. And so I encourage patients, and I would encourage this patient who's written in to say, absolutely, get another opinion. It shouldn't be offensive in any way. I'm certainly not offended as a physician. What I want my patients to have the information they feel like they need, and to feel a sense of confidence and peace with the decision. It's really important, I think, when we're talking about these big procedures with risk, and there's always risks, especially in brain and spine surgery. I want patients to feel like they're making the right decision for themselves, and that's a very individual thing. And if you're asking the question of, boy, should I see another doctor? My answer to you is yes, absolutely. You definitely should see another doctor. And I think you should keep asking questions and see whoever you need to see until you say, I think I feel comfortable with my decision.
When seeking, I guess, the input of another doctor, do you ask the doctor you're seeing, hey, can you help me find another doctor to get a second opinion on this? I mean, to me, it just sounds like an insult to ask that. So
patients, it's not just you. Patients will often seem kind of a little hesitant or a little bit like bashful about asking the question. Gosh, and they'll say oftentimes when I'm in a room with patients, gosh, doc, nothing personal, but should I get another opinion? Again, yes, and I'll often offer them, hey, I would be happy to help you find another doctor. And I'll also offer them, would you like to see somebody within the practice for a second opinion, or would you like to see somebody outside of the practice? Because sometimes within a practice, sometimes we develop similar ways of doing things. It helps for Hal Allen. We've got 15 surgeons, so you do get a variety. But sometimes patients will say, I would feel more comfortable going to a university. I say, great. Let me try and make a referral to Vanderbilt for you. Let me help facilitate the second opinion, because we want you to get all the information you need to make a decision.
The person with CRPS texted back in and they asked, how often do you see it go into remission? First of all, CRPS, is it that painful? Are we talking similar to a backache? What are we talking?
My understanding, it's not my expertise or my area of specialty, but what I will say is I've definitely had occasional patients with CRPS, and it is really painful. I'm sure it can run the range, and there might be some patients who say it's not that bad, but I've seen patients who are truly, truly suffering from CRPS. Remission is a term that I often associate with cancer, like you've beaten the disease and now it's getting rolled back or it's being controlled. So I don't know how often CRPS goes into remission in a sense of speaking, but what I will say is I've definitely seen patients who are in a good place under the care of an interventional pain management physician. That's a physician that specializes in pain management and oftentimes can do nerve blocks, injections, that sort of thing, who have a better quality of life. But I don't know if there is such a thing as a cure. And that I think just reflects a lack of knowledge on my part of something I don't really treat very often.
Again, this morning from Ascension St. Thomas Rutherford and the Hal Allen Clinic, we are talking to Dr. Ernest Wright. And another question we had here, it says they're experiencing a lot of hand numbness, and they notice especially in the morning, along with extreme neck aches as well. What would you suggest I do as a starting point?
Makes me think of two things. Hand numbness when you wake up from sleep, it's a pretty classic symptom of carpal tunnel syndrome, which is pinching of a nerve at your wrist, and that's the nerve that does sensation in your hand. So patients who wake up from sleep and have really bad numbness, you find yourself shaking out your hands, or if it awakens you from sleep, you wake up in the middle of the night and you're like, man, I just got to shake out my hands. These things are so numb. That is a classic sign of that pinched nerve at the wrist. So that's one thing to get looked at. Then the other thing too is if you're having numbness in your hands or arms and you're having a neck ache, that is usually a sign that you've got some stenosis in your neck and you might have some nerve pinching in your neck. So I would tell that patient just to give their PCP a heads up, their primary care physician a heads up, let them know, and they'll make sure to get them taken care of. And certainly we're always happy to take care of you. But something I think shouldn't be ignored, probably want to get it looked at just so it doesn't get worse.
And carpal tunnel syndrome, I mean, that's something we, I guess, first started hearing a lot about. Seems like in the 90s, when people were typing a lot more on old-fashioned typewriters, but it's obviously still an issue for a lot of people. Yeah,
exactly. I remember that very well. That was when all the gel hand rests started appearing in front of everybody's. I don't know if the gel hand rests have fixed anything, but it does seem to have become much more prevalent with that hand positioning over a keyboard. And the good news is there are some non-surgical things that can be done. Braces, injections, that sort of thing. So it's not always something where you need surgery, but if you're having hand numbness, you want to catch that before it becomes hand weakness.
Yeah.
You know, your hands are so fundamental to everything you do in life. If it goes undiagnosed and you just kind of ignore it, you can really start to lose some function in your hands.
I remember that's when all of a sudden you start seeing hand or wrist braces in all the Walgreens and everything.
Yes.
But it kind of hit all at once.
Right. Yes.
You know, it's interesting to think about carpal tunnel and how we're scrolling on our cell phones.
Yeah.
I feel like that's probably increasing the prevalence of that.
Probably so. Yes.
We're going to see a lot of cell phone injuries in the near future.
Yes, I think so.
Last question here. How advanced has brain surgery become over the last 10 years?
I'd say dramatic advances. I wouldn't say just over 10 years, but I think over the last 20 and 30 years, it's really advanced a lot. And I'll give you a couple really cool examples. I think one thing that it is really helpful is there's a GPS system for the brain that we use in the operating room, and we've got that at St. Thomas Rutherford, and it essentially allows you to find wherever you are in the brain on the patient's MRI. So there's a little pointer that you can hold up to the brain, and we've got this beautiful big screen with a picture of your MRI on there, and wherever you put the pointer, it shows exactly where you are in the brain. And the way that really changed brain surgery is that in the olden days, when you didn't have that, you actually had to make these really big openings to do brain surgery because you couldn't be sure where you were. So you'd have to really open up the skull and take a look. With this GPS system, what you can do is you can basically, before you've ever made any sort of incision or anything on a patient's head, you know exactly where you are. So you can make a really small incision, which means shorter surgery, less blood loss, lower risk of infection, and get that surgery done quicker, safer, less pain in the recovery process. That's not really a last 10 years kind of development, but I would say between that and some of the other really great technological advances, it's made a really big difference for us in brain surgery.
What is that they say about if the air hits the brain or something about brain surgery and the problem of opening up the brain, I guess?
Yep.
You open up the idea of all these additional problems that could come. At least, I mean, that's how it used to be. Is that still the case?
Much less so. So infection rates in brain surgery are really, really low nowadays with just all the different tools we have for antisepsis and keeping the skin clean during surgery. I'd say brain surgery is much lower risk. You know, the risk of brain surgery a generation ago was really, really high, and it's come down a lot. And it's come down a lot, not just because of one thing. I'd say it's come down because of 1,000 little innovations that I'd say science and industry have given us, and it's really made it a much safer undertaking.
Again, with us this morning, Dr. Ernest Wright and also Daphne David. Ernest is with the Hal Allen Clinic, and of course Daphne is over the Ascension St. Thomas Rutherford Hospital right here in Murfreesboro. Thank you both for joining us this morning.
It's a pleasure being here. Thanks so much.
Hopefully we answered a lot of questions for folks out there. We will see you guys again in the near future.
Nice to be here.
Hopefully
Thanks
not
again.
at your office. All right, take care.